Good afternoon, everyone. I'm Dr. Avantika Dhakre. I'm a final year resident at Patil Hospital from India.
Yeah.
Okay.
And now, Dhakre from Patil Hospital, India, please start.
Thank you, ma'am. So I'm here to present a research that my Department of Obstetrics and Gynecology from Patil Hospital, Kolhapur has been doing since the past 10 years. It was on surgical interventions for endometriosis and its long-term outcomes and recurrence rates. So in India, late diagnosis and limited awareness contribute to advanced disease at presentation. However, recurrence after surgery is common, up to 27% within 2 years without hormonal therapy. Hence, now, since after this study was conducted, we realized that post-operation, if we give any hormonal therapy, then recurrence rates had reduced significantly. Emerging conservative surgical techniques like carbon dioxide laser vaporization offer promising fertility outcomes with low recurrence. The present study compares long-term outcomes of laparoscopic excision, ablation, and abdominal hysterectomy with bilateral salpingo-oophorectomy in endometriosis patients over 10 years, evaluating their pain relief, recurrence, fertility, quality of life, and reoperative rates to determine the most effective surgical method. The aim of the study was to determine the long-term outcomes and recurrence rates of endometriosis for various surgical interventions. The study was conducted at our department in Kolhapur, and the duration was of 10 years. With each patient, we had taken a follow-up of up to 10 years. They were called for follow-up in the first year after 3 months, 6 months, and then yearly for up to 10 years. The inclusion criteria for our patient group was women of reproductive age, diagnosed with endometriosis and scheduled for excision, ablation, or hysterectomy. Exclusion criteria was women with prior hysterectomy, oophorectomy, any malignancy, pregnancy, any major comorbidity, inability to come for follow-up up to 10 years. The sample size was of 948 women, from which 318 underwent excision of ND deep endometriotic nodule, 316 went for ablation, and 314 underwent hysterectomy. The study parameters had a primary outcome as well as a secondary outcome. The primary outcome was symptomatic recurrence defined on the visual analogical scale, which was calculated for 3 months. And the secondary outcome included imaging confirmed, imaging as in USG and MRI confirmed, relapse or spontaneous pregnancy, reoperation, and quality of life. The data analysis was done using Kaplan-Meier survival analysis and multivariable Cox regression. So the results were a pain reduction at 12 months. All surgical groups showed pain reduction, but hysterectomy achieved the greatest improvement. In the VS pain ratio, hysterectomy with bilateral salpingo-oophorectomy was at 65 mm, followed by excision at 48 mm and ablation at 38 mm. 10-year symptomatic recurrence, here also again, hysterectomy proved to be the best with best outcome. Only 8.3% patients had symptomatic reoccurrence, followed by excision, which was 33%, and then ablation, which was 56.3%. Then for relapse, which was confirmed by imaging studies, hysterectomy again proved to be best, which was 4.8%, followed by excision and then ablation. For spontaneous pregnancy rates, hysterectomy was not applicable. Excision proved to be better than ablation with the pregnancy rate of up to 61.7% with excision of endometriotic nodule and 43.6% after ablation. The major 30-day complications were least with abdominal hysterectomy with bilateral salpingo-oophorectomy, 3.5%, and excision was 3.1%, and ablation was 2.9%. In the quality of life index, hysterectomy showed the greatest long-term quality of life improvement, followed by excision, However, the selection of hysterectomy is of utmost importance, as in we cannot do it for the patients who require fertility. So only with advanced diseases, or if the family of the patient is complete, hysterectomy has proven with better results for lesser chances of reoccurrence as well as for improved quality of life. Reoperative free survival at 10 years, hysterectomy had the lowest reoperative rate. Excision was significantly better than ablation. Now, the protective factors against reoccurrence. Continuous hormonal suppression significantly reduced reoccurrence risk. Hence, it was proved that post-operatively, if we give any hormonal support or else in the form of combined oral contraceptives of progestin-only pills, the reoccurrence was much lesser, and also it improved the deep infiltrating endometriotic lesions as well. The mean age for the hysterectomy patients was much older and they had much advanced disease. The mean age was 38, and the recurrence of stage 3 and stage 4 of DIE was 93%. And the least mean age was for the patients of excision, and the stage 3 and stage 4 recurrence was of 66%. This study presents a comprehensive 10-year comparison of 3 surgical strategies for endometriosis, which was laparoscopic excision, ablation, and total hysterectomy with bilateral self-ing oophorectomy. Hysterectomy provided the most durable pain relief and lowest recurrence, but eliminated fertility, making it suitable only for women not seeking future pregnancies. Laparoscopic excision outperformed ablation, showing lower recurrence rates, higher spontaneous pregnancy rates, and better quality of life, confirming its superiority for women who are willing to preserve their fertility. Post-operative hormonal therapy significantly reduced recurrence risk, while smoking and incomplete excision were identified as independent recurrence predictors. Overall, the findings emphasize individualized surgical planning, hysterectomy with bilateral self-ing oophorectomy for definitive pain control in non-fertility seeking women, and laparoscopic excision as the optimal balance between efficacy and fertility preservation, supported by routine post-operative hormonal suppression. Surgical radicality dictated long-term success. Hysterectomy offered the most durable pain relief with minimal recurrence, but eliminated fertility. Ablation should be reserved for carefully selected low-burden cases or resource-limited settings, that is India, as we being a resource-limited setting. For the women seeking fertility, ablation is one of the good methods for deep infiltrating endometriosis. All patients benefit from post-operative hormonal suppression and lifestyle optimization. Thank you.
Thank you. I now take this immense pleasure of inviting William Hart to felicitate Avantika Dhakre certificate.
Question. Very nice.
Thank you, sir. Thank you.
I do have a question. What kind of hormone therapy did you give afterwards, and for how long? What was the standard?
If the patients underwent excision or ablation therapy, in which the uterus was preserved for fertility, we did give levonorgestrel intrauterine system. But for the patients who underwent hysterectomy, we gave them low-dose progestins or else combined oral contraceptives if they were perimenopausal or menopausal. It also reduced the symptoms of early menopausal hot flashes and other symptoms.